to the first edition of the Australian Health Journal. I'm Dr. Anne-Marie Kazidlo.
And I'm Helen Suaning.
In each of our shows, we will cover current developments in the world of healthcare to better inform those in the industry, as well as those interested in it.
Healthcare is complex and fast growing, and no one, not even within the industry, can keep abreast of the new treatments available for each condition and other changes in delivering patient care.
Australian Health Journal becomes your primary viewing channel to help you, help your patients make informed decisions on their healthcare needs. You'll hear about progress in research and in clinical trials, as well as broader changes in healthcare within Australia. Our aim is to bring healthcare professionals together to hear about new treatments in patient and consumer care.
In today's edition of Australian Health Journal, we bring you news of new drugs added to the PBS. By the time this show is broadcast, the Australian Federal Government has added 3 new drugs to the Pharmaceutical Benefits Scheme. These changes bring significant savings to patients being treated for multiple myeloma, cystic fibrosis, ALK-positive non-small cell lung cancer. More details on these changes and the drugs to treat these conditions can be found on our Facebook site. In other news, last year's Australian H3N2 strain of influenza have reached the UK, with predictions it could trigger the worst flu outbreak in 50 years. UK authorities, such as Simon Stevens from the NHS, are bracing for similar strain on the hospital systems as those faced by Australia. At least 170,000 cases were recorded in Australia, twice as many as in 2016, leading to over 700 people having died due to this particular strain. First to Dr. Jason Pace, a practicing Sydney psychiatrist since 2003. Over the past 4 years, Dr. Pace has been focused on transcranial magnetic stimulation, or TMS as it's known, for the treatment of depression. TMS technology has been studied for over 20 years and is now available to the Australian public. Through his clinics, Dr. Pace is hoping to make TMS more accessible to patients with treatment-resistant depression, where medication has been found to be ineffective.
Hi, I'm Jason Pace. I'm a psychiatrist working in New South Wales and Sydney, Australia. I've been involved in private psychiatry since 2003. My first venture was working with a group of doctors setting up a practice called the Hills Clinic. The Hills Clinic is a multidisciplinary team approach to psychiatry and private practice, and we owned a hospital and a few clinics until a couple of years ago. Since 2014, I've been involved with transcranial magnetic stimulation, or TMS, as it's easily known. TMS is a magnetic treatment for depression. It's a medication-free treatment for depression, and it's for people who've tried medications and have failed, tried several medications and not had the response they're looking for. So we're getting some fantastic results. We have offices in Metro, New South Wales and Sydney, and we're probably treated around 150 patients in this last couple of years and getting response rates of around 60 or 70%. Considering these people have already been on lots of medication, some of them have been depressed for a decade or more, I think they're fantastic results. So TMS, or transcranial magnetic stimulation, is a way of delivering a pulsating magnetic field over the prefrontal cortex of the brain, or the front of the brain, and these are the areas we think are involved with depression and other mental health issues as well. The pulsating magnetic fields penetrate about 2 centimeters into the brain, and this creates a huge amount of activity, electrical activity and blood flow activity in the underlying brain structure. And the theory being that reactivating these parts of the brain helps reactivate normal behaviour and subsequently improving depressive symptoms and other symptoms as well. TMS has been around for a while. I mean, most people haven't heard of TMS, in fact, but it was actually probably about 20-30 years worth of research in TMS worldwide. It was approved by the TGA in Australia in 2007, and it's really laid dormant very much for the last 10 years. There's a few research units in Melbourne and in Sydney who've taken on TMS machines, but really nothing much has happened with it, largely because Medicare funding hasn't been forthcoming. The College of Psychiatrists has applied twice for Medicare funding for item numbers for TMS and has failed on both occasions. Not because of efficacy, it really comes down to a cost issue for the government. So Look, when we started in 2014, we knew it was going to be a slow build. It's sort of a thing that, unless unfortunately you can afford a treatment that's around about $5,000 treatment for the course, it is going to be difficult for a lot of people to access this treatment. So subsequently, the people we've been treating have been people who've been quite severely depressed. I think most psychiatrists are sending us really the most difficult types of depression that they're really struggling with. And we love that, we love the fact that, we're having a go at treating the very most difficult sort of types of depression. I think when the psychiatrist sees the results we're getting, they're obviously sending us more patients, but it's been very hard to convince psychiatrists, I think, to even start looking at TMS. There's such a space of using medications and other therapies that TMS has been difficult to penetrate, I think, into the psyche. Even though the college has guidelines for TMS, it's still been a difficult thing to introduce. GPs, on the other hand, have been much more receptive to TMS, and they've been probably referring more patients. But ultimately, the patients tend to find us themselves. Patients are very much on Google and researching stuff for themselves, particularly when they're so desperate with their depression, and families of patients as well often find us directly. Well, I think one of the most exciting things about TMS actually is the side effect profile, because it is very, very well tolerated, and there's been research comparing TMS, CCT and medications, and TMS always comes up front as far as patient preference. It's a very easy treatment to deliver. It's certainly some discomfort in the scalp where the coil sits. It feels, I think most people say it feels like a woodpecker sort of pecking on there, or like electrical sort of static. It's something that people get used to very easily though. I think in the whole time we've been practicing, we've had 2 patients who've stopped the TMS because of the pain. Most people within about 2 or 3 sessions get quite used to it. We've got people even fall asleep on the chair while they're having the TMS, so it's very well tolerated. Side effect profile, look, there's really no systemic side effects that we're concerned about. It's very directly affecting the part of the brain that it wants to. It doesn't really affect other parts of the brain or other parts of the body. The main serious side effect is seizures, and these are extremely rare. So 1 in 30,000 chance of having a seizure while you're on the TMS treatment, and that's, compared to other things, that's a very, very low risk. We're obviously prepared for that, but I don't believe there's been a clinic anywhere in Australia that's actually had a patient have seizures, but it's certainly a theoretical risk. Apart from that, look, it's extremely well tolerated. I think people who come to the clinic sometimes get a little bit anxious, but usually within sort of an hour or 2 of being here and showing them around, usually they get very comfortable with the idea. Sometimes people can get a bit of lightheadedness, maybe a little bit of dizziness after the treatment. Some people feel a little bit tired, a bit sort of fatigued, but usually they get on and do their normal day's activity. So they drive themselves here, they drive themselves to work or back to home, and really there's not much consequences as a result of the treatment. So the sort of results we have do vary quite a lot. We do get also quite a variety of different patients that we see. In the clinics, certainly there's some of the patients, my own patients that I've referred to the clinic, and other patients I don't know that well because they're coming from other psychiatrists or GPs. The patients will tend to come in about 3 times to 5 times a week, 3 times at a minimum, and we see them for 30 treatments. So usually we get to know them reasonably well over the time of that period. And look, the nurses and myself are always pretty blown away by the quick change in their persona. They'll often come in feeling quite anxious, looking very flat, very downhearted. And by the end of the treatment protocol, sort of 5, 6, 7 weeks later, they're coming in, they're bouncing in, they've got brighter eyes, they interact with you more, they're sort of talkative, and they just feel different, And it's not uncommon to hear from patients, my family and friends tell me they haven't seen me like this for 10 years, and that stuff is quite commonplace in TMS treatments. The patients who tend to do the best are people who are going to respond usually between 20 and 25 treatments. Occasionally we see people responding a bit earlier as well, and typically most people who respond are going to stay well for a long period of time. So studies would tell us that about 70% of patients would remain well at a 12-month follow-up. Occasionally we do see people, probably like I'd say around 20% of patients, who do relapse earlier. The wonderful thing about TMS is once you've responded, typically you'll respond again to the treatment. And we've certainly had a few patients who've decided to go on a maintenance protocol for TMS now, where they're coming in maybe once a month or twice a month. And they've managed to reduce or even stop all their medications during that process. And then we'll just see them once or twice a month for a top up, and that's keeping them really well. I think the longest patient we've had is been at it now almost since we started, about 2.5 years. We've got 2 patients who are on maintenance for 2.5 years. And they're yet to have a relapse, so they've been very, very well over that period of time.
In our monthly shows, we cover the career highlights of healthcare professionals. This month, we hear from Australian Health Journal host Dr. Anne-Marie Kazidlo, who also works as a dermatologist in the Newcastle region of New South Wales, as well as being the host of consumer health show Recover Me.
The most important turning points, I think, for me have been when I've actually decided to get into medicine. It was obviously a huge decision to make because I know how much of a commitment getting into medicine would mean, but I think it was the time that it allowed me to actually become who I am as a person. So caring for people is just such a big part of my life, and getting into medicine was exactly what I was destined to do. So I embarked on that journey, and certainly haven't looked back ever since. So it's been a continual process of learning, of getting into new areas, of helping patients, and every day is an absolute blessing and a privilege from my point of view. But I guess it's usually in general the ones where the patient is a young person that has a family who are growing up, and they would absolutely love to see their children grow up and to develop and to progress into adulthood, and they have a condition or a disease that's actually going to prevent them from doing that. So it's a situation where I really cannot detach myself. As a human being, you can't help but feel something for that patient, and it really does have an impact on me. And I guess that's why I try my hardest to make sure that every facet of that patient's care is covered well, and that they're actually feeling that I'm going on this journey with them and that they've got support. So when we talk about a patient's recovery or their treatments in general, we really do focus on the holistic approach. You can't really just treat a patient medically and give them a pill and everything goes away. There's a whole psychological, emotional process that patient really does need to go through, and we do really need a whole bunch of people, including family members, psychologists, allied health, who get involved and help that patient to actually progress and go on that journey towards recovery. So it really is, everybody pitching in, helping, supporting, and making, in the end, that patient's recovery possible.
Let's now hear from Professor Andrew White, Head of Ophthalmology at Westmead Hospital, on an award-winning eye monitoring program operating in clinics in Western Sydney. The program has reduced glaucoma patient intake by 50%.
I'm Associate Professor Andrew White. I'm a consultant ophthalmologist with an interest in glaucoma. I'm Head of Department of Ophthalmology at Westmead Hospital and Director of the Community Eye Care Project.
I'm Belinda Ford. I'm the Service Coordinator for the Community Eye Care Project.
In Australia, there are approximately 900 or so ophthalmologists who are active across the country. We know that somewhere between 10 and 13% of those people have subspecialty interests in areas like glaucoma. There are approximately 6,000 optometrists also in the country. We know that the number of people who need to be seen for either diabetic eye disease or glaucoma is probably a little over 1 million people, and so it's pretty obvious to see that if only ophthalmologists with a subspecialty interest in the eye diseases that we're focusing on could see these patients, we simply don't have enough capacity to do it. However, the real challenge is to make sure that people who simply require monitoring for these eye diseases rather than active treatment are seen in a safe way and not lost in the system. One of the big challenges with eye care, particularly in Western Sydney, is capacity for people that need monitoring for eye disease but not necessarily treatment. Our eye clinic has 25 consultant ophthalmologists and sees 30,000 patients a year. We're the only public hospital clinic in Western Sydney. Within the region, we know that there's approximately 14,000 people with glaucoma and probably that many again that need monitoring. We also know there's about 130,000 diabetics, about 30,000 of which probably have some sort of diabetic eye disease. It's not possible for us to see them all, but often these people have nowhere else to go, and so we've devised a system such that these people can be safely monitored in the community and only come into the eye hospital when really needed. Community eye care is a system whereby people who require monitoring for glaucoma and diabetic eye disease are seen in a community setting by qualified optometrists who send reports of a standardised examination to us electronically for review in the clinic. Only the people that actually require treatment come into the clinic, and the remainder continue to have monitoring in the community by those optometrists. So how the system works in practice is all patients that require an eye review for either glaucoma or diabetes in the public hospital clinic at Westmead get a referral sent to us for assessment. People that are deemed to be suitable for assessment in a community setting through the CIC project are then referred onwards. The people who are most suitable for this kind of system are the people who we consider to be at low risk of blinding eye disease, or we simply don't have enough information on the referral. The patients who are not suitable for this system are people with clearly imminent danger of vision loss from blinding eye disease, people who require surgery or have had previous surgery or laser treatment for glaucoma or diabetes, and those who are known to have advanced disease or only one eye. So suitable patients are then referred on to our community eye care centres, where a standardised assessment including retinal photography and visual field testing is performed by qualified optometrists. Those test results are then transmitted electronically to us, as well as a clinical decision made by the optometrist. Only those patients that are deemed to require active treatment pending review by one of our ophthalmologists in the eye clinic are then referred into the eye clinic for that treatment. Patients that simply require monitoring at known intervals continue to have their assessments at the community eye care centres.
So we started a trial of community eye care in January 2017, and until December 2017 we saw 750 patients. Some of the outcomes of the trial showed that 50% of patients who went through the trial did not need to come into the hospital for a further follow-up appointment, and that resulted in a 7 to 8 week reduction in wait list at the hospital.
I'm the director of the CIC project, and I work very closely with Belinda here, who coordinates the patient flow and the clinical outcomes. Under this structure we have 2 other ophthalmologists who electronically review the findings transmitted by our optometrists, who are at 2 centres in Parramatta and Blacktown. We hope in 2018 to move from a pilot phase, which we had in 2017, to fully integrating a sustainable model of care into our regular models of care in the eye clinic. We're looking increasingly at what happens to the patients who are being followed up in Community Eye Care Centre, in addition to the stream of new patients that we see every year.
And we're working closely with the other hospital departments to make sure that we can streamline all the processes and it can fit in with the hospital systems that currently operate. So I started to work in health because I really thought it was important for people to have better health and that they would be able to get better access to services. The health system in Australia is quite complicated and people can find it hard to find the service that they need at the right time. So when the CIC project came along, I thought it was a great opportunity to get involved and help people to access the right services, get the right treatment, and also make the health system more efficient so that more people could have access to better services.
I became an ophthalmologist from actually a laboratory-based background, and I was always fascinated with how the eye worked and how that we see. And then as I moved on, I thought that was all very well, but I wanted to give a tangible benefit and help people see better, particularly when the system was not working so well. And so I became an ophthalmologist, and I've been a consultant ophthalmologist since 2011. I've worked as a consultant in the UK and Australia. When I came back to Western Sydney, which was principally my training ground as an ophthalmology registrar, it became immediately apparent to me that there was a number of people who were effectively taking up the position of others who needed treatment just to be monitored simply because they had nowhere else to go. And at the same time, I could not get to the people with potentially blinding eye disease fast enough. And I realised there had to be a better way, so I adopted a model that I had used previously overseas to Australian conditions, and the idea of the CIC project was born, and I'm very pleased with how successful it's been so far.
Now we hear from Professor Gregg Suaning from the University of Sydney on his work on the bionic eye. Phoenix 99 is now entering the clinical trial phase, having successfully created 99 stimulation channels for 3 patients having profound blindness.
My name is Gregg Suaning. I'm a professor of biomedical engineering at the University of Sydney. My field of research is in neurobionics, where we try and modulate the nervous system to produce beneficial outcomes for patients. My field of research is in neuroprosthetics. We work with cochlear implants for the deaf, we work with bionic eyes for the blind, and we work with neuroprosthetics to help movement disorders, such as the capacity to blink when you have facial paralysis, or movement disorders in the lower limbs to restore movement. Neuromodulation is the intervention into the nervous system where we can change the behavior of nerve cells, and for instance in blindness we can make inactive nerve cells active again by sending electrical impulses to them. The signals that are activated then travel off to the brain, and the brain interprets those signals as vision. The same thing happens with cochlear implants. You can activate nerves from the auditory system, and those signals travel to the brain and are interpreted as hearing. The same sort of thing happens with movement disorders. If we wish to make the left foot move, for instance, we can find the nerve cells that travel to that foot, and we can activate those with electrical stimulation and make the foot move. In our research in bionic eyes, we're primarily looking after people with retinal degeneration. That is, a healthy eye other than the part that acts as film on the back of the eye, such as the retina. So photoreceptors are the cells that are typically targeted by these nasty diseases such as retinitis pigmentosa and age-related macular degeneration. And by bypassing these photoreceptors, we can then deliver stimulation to the surviving nerves and restore vision. Bionic eyes have been researched for many decades. In fact, in the 1950s, there was a patent by a fellow by the name of Edward Tassiker in Australia that was the first one to put forward a device that was implantable that could conceivably restore vision. Since then, researchers have been working very hard to get a viable device, one that is actually beneficial to human beings. Now, our visual system is so complex that a human-made intervention that tries to replace it is a very tall order. However, we've been making some excellent progress over the years. In fact, you can now purchase a bionic eye in certain parts of the world and get some rudimentary vision happening with certain types of blindness being treatable. With our approach, we are putting our electrode array in a particular location of the eye called the suprachoroidal space, which is behind the retina and behind a layer of blood vessels. And from that particular spot, we are able to comfortably put an electrode array that can last for decades in that position, and we can deliver our electrical impulses that activate nerves that restore vision in a way that others have so far been unable to do. Haven't been able to restore vision for a long period of time and deliver it in a safe and efficacious way. So our project began in 1997, and at that point we had no funding whatsoever, and so we were taking apart old stereos and automobiles and using parts from those particular devices to build electronics that could stimulate the nervous system. We gradually gained a little bit of traction, we demonstrated some successes, and funding started to come in from the various regulatory, or various funding bodies rather, and we were able to build a system that was able to stimulate the visual system. Now, since then, we've refined the system over and over and over again, and at this point in time, we have a number of organizations working on the project that contribute in their own unique ways. We have the University of Sydney, we have the University of New South Wales, and two medical research institutes at Save Sight Institute, which was part of the University of Sydney, and at Westmead Hospital, which is also part of the University of Sydney. So the medical side of things is taking place at those two institutions, and the engineering and technology development is taking place at the University of Sydney and the University of New South Wales. Where we've come from those humble beginnings is to have an actual device that we call the Phoenix 99. Now this has 98 channels of electrical stimulation, and it has a reference electrode which makes up the 99 stimulation channels. Now you can imagine if you've gone to a concert or a stadium of some sort that has a display that is made up of dots of light, and you can make out pictures, you can make out numbers, and very rudimentary type figures, and we believe that we're going to be able to deliver those sort of things with our 98 channel electrode array. Where we've come from there is to make that technology known to be functional. So we've tested this in what we call in vivo, which is in animals. We've tested the electrode array itself in 3 human beings, and we've been able to get them to respond and say that in fact they do receive some input from the device, which has been extremely encouraging and has brought us to where we are now, where we're preparing with our research partners to initiate a small-scale clinical trial of our device. So our research has come a long way, and the next step is to implant our device in a small cohort of human patients. Now, we've already done a small-scale trial with I guess what you would say is a mock-up device. It didn't have the active electronics. There was a connector that was behind the ear, and the electronics could, in the laboratory, be connected to this electrode array that was implanted in these 3 people. Now, that limited the study to only what could be accomplished inside a laboratory with a very short time frame. This will allow us to send people home, allow them to carry out their daily activities, and give us important feedback on how we can improve this device. We not only will have a greater number of channels, but we'll have the greater flexibility in terms of how the people use the device by giving them the control over what sort of modalities would they like to see. Would they like to see edges? Would they like to see where faces are? Would they like to see where doorways are, and those sort of things. So enabling the person that's wearing this particular device and has the implant to tailor the input to their specific needs is going to give us a huge amount of data to help improve things further. An important aspect of this is managing expectations. So we have a number of people that have actually called us and said that we would like to that they would like to participate in our study. Many of these people have poor vision, but they have some vision left, and it's extremely important for us to make sure that the first recipients of our device are what we call profoundly blind, where they cannot see anything but maybe bare light perception, because there's simply too much to lose if what we have is not good enough. So initially we will implant around 5 people with severe cases of retinitis pigmentosa, and try and give them the expectations that this device is very experimental, may not restore vision, but may actually be something that's beneficial in guidance, in navigation, in helping people carry out their activities of daily living. That's our objective. We have 100 channels to work with. You can imagine what you can convey with 100 channels. There's actually quite a lot of information you can convey, but it's by no means what most people enjoy as true vision.
Thank you for watching Australian Health Journal. If you represent a healthcare organisation that's developed new treatments for patients or consumers, please get in touch and we can let other healthcare professionals know in an upcoming show. Thank you for watching, and from myself and Helen, until the next show, goodbye.